Welcome back to episode 49 with an amazing physician that we miss very much here at UF Health, Dr. Natalie Lockney. She is an assistant professor in radiation oncology, at Vanderbilt University Medical Center and the program director for the Radiation Oncology Medical Residency. She was a summa cum laude graduated at Birmingham-Southern College. She completed medical school at Vanderbilt University School of Medicine. Prior to her residency training at Memorial Sloan Kettering Cancer Center, where she served as a chief resident from 2016 to 2017. Then she practiced at the University of Florida and at Sutter Solano Medical Center before joining Vanderbilt in 2021. She's a board certified in radiation oncology and specialized in treating patients with malignancies of the gastrointestinal tract, head and neck, and breast. So Dr. Lockney, thank you so much for being here with me today.
Well, also, Shirley, thank you so much for inviting me. Really excited to join in. So thank you for the invitation.
Absolutely. So you want to tell us about your journey?
Yeah, absolutely. So I'm a radiation oncologist, meaning I'm a doctor who specializes in using different forms of radiation, the most common being X-rays, typically to treat patients who have cancer. I didn't always know that I wanted to be a doctor. There were no other doctors in my family, but my grandmother was a nurse, and she really loved education and learning, which was very impactful on my life. And then my mom and several family members were secretaries or administrative assistants for an oncology practice. So I would always hear stories about the patients that they would see coming in and how special those patients were to them. They really loved being able to greet patients each day, knowing that they were going through a really difficult time in their lives. And my own grandfather actually was a survivor of, multiple types of cancer. And eventually it was heart disease, not cancer, that ended his life. But I know, each of his cancer journeys were very difficult for him. So it really wasn't until college that I started thinking about going to medical school, since I really loved a lot of my science classes and thought I would really enjoy interacting with patients. And I knew that the cancer patient population was really special to me. And then it was when I was in medical school that I learned about the field that I'm in, which is radiation oncology. I think a lot of doctors don't even know always that radiation oncology exists unless they're cancer doctors. But it's a really unique field in that it uses technology, physics, cancer biology, radiation biology to really all come together to treat a patient. And I really loved the combination of that technology, as well as a really extended amount of time with patients. I really love the patient interaction as well. And radiation oncologists, actually, compared to a lot of other physicians, really do get a lot of time in clinic with their patients to really have longer conversations. And so when I found the field, I knew that's what I wanted to do.
That's great. That's really good. So have you ever thought about doing something else besides radiation oncology, or pretty much that was something that pretty much you decided to do when you were in med school, not really deviations from anything else?
Yeah, that's a great question. I think a lot of medical students come in trying to decide, do they want to do a surgery specialty or a non-surgery specialty? And I definitely knew I really didn't want to be in the OR. I thought a lot of the blood and things like that were going to be hard for me in medical school, and it was a little hard to get used to this. So I knew I didn't want to be a surgeon. I knew I wanted to do something in oncology. So at first I was thinking about medical oncology until I learned about and became exposed to radiation oncology.
Got you. Will you give us 3 valuable tips that you learned to your journey for yourself and as well with patients with cancer?
Yeah, absolutely. I think the first is to really try and be honest with yourself, whether that's because you're the physician or the patient. And I think from for the patient perspective, you really want to be honest with your doctors and your whole team on what your goals of care are. I think it's helpful for patients to be honest about their fears and concerns. And their true symptoms. So the whole medical team, we really do want to help patients, and we don't want patients to be afraid to ask questions, because it's really our patients who are growing through the treatment, not us. The second thing I would say is I think it's important whenever we're going through something difficult, so whether that's with our career or your cancer treatment journey, that it's important to try and surround yourself with things that make you happy when you can. And so when you're going through a cancer treatment, there may be physical things or even, mentally challenging things that you can't do because of side effects of treatment. And so I know that there may be barriers to this. But if there are things that you can do that you've enjoyed doing before, whether it's watching a movie or a TV show, spending time with, an animal or a loved one, or, even spending some time outdoors in the sunshine, I think it's important to do that and do something that makes you feel more normal and not just like, a cancer patient at a period of time. And then finally, I think the third and I would say even the most important thing is it's always important to find and lean on your support system. Mm-hmm. And everyone's support system looks different, and the support system can come from a lot of different places. So it could be family or friends, it could be medical team, it could be support groups. I think it's important that everyone knows that they're not alone. And even if that support system isn't in person with you, we're now in this virtual era where you can also connect with people in so many other ways, even over things like Zoom or FaceTime or, internet groups.
Absolutely. And I think this is so true. Sometimes as a human beings, we tend to not bother people around us, or we don't want to, we don't want to bother, we don't want to worry people about us. And so we think we can do it alone. And it's such an easier way to do it when you have somebody you can just really lean on to it. And you're right, sometimes we see patients, and this is a really great thing as well about my career, where we can spend a lot of time with patients, and then we become their psychologists and their, it's like try to really advise them, like, other areas where they can go and seek for help, counseling, or many times they come to us and it's like, I'm not sure if I should be asking my radiation oncologist these questions. And it's like, no, absolutely. And I try to guide them into all the valuable information I've been learning through you and some of the other radiation oncologists who I work with. But it's important for us to really be able to just say, this is important for you. This is what I'm thinking can be the reasons behind, but you need to go back and ask your radiation oncology those specific questions. Because sometimes, the patients feel like they're bother you, or you're too busy to listen to them. Or sometimes it's certain physicians out there that are really too busy to listen to their patients, and they're just in and out of the room. So it's important for them to know, like, they have the power to say, no, I need to get an answer for these questions, and they start to really seek for the help that they need, or to get answers to those questions. So.
Yeah, absolutely. I agree.
Yes. So how about a painful lesson that you learned through your journey?
Yeah, I would say, I think something that can sometimes be very painful and hard for physicians is, I think we all know, you can't certainly cure everyone, but it's also hard if you can't even help someone. There are a lot of treatments that we give to patients that we know when they can't be cured that can still help them, maybe help their pain or certain symptoms they may have, like bleeding. But I think what's a little more challenging is when there's someone that you can't, even help, because maybe that the options that you have would be too hard on them or too toxic for them. And then sometimes too, a patient or family may be in a place where they don't necessarily want help, and that can be hard, because I think as physicians and medical providers, a lot of us go into the field because we really have this drive to want to help people. But I would say, even when you can't help someone, you can still be present for them. And I think just being there, and even if it's a resource for in the future and someone to reach out to for the future, can be helpful in its own way.
Perfect. So going a little bit more into the detail of radiation for some of the audience. So would you explain to us a little bit about, okay, what is the difference between this electron therapy versus proton therapy, and what would you advise, and again, I know it can be multiple reasons why one versus the other, but if we're looking into, like, breast cancer, for instance, would you just explain a little bit more in depth to the audience about that?
Yeah, absolutely. So we can use breast cancer as an example to kind of explain. And so, the most common type of radiation that's given is photons, which is X-ray, but as you mentioned, some other types of radiation that may be used in more specialized areas are electrons or protons. And both of those are charged particles. And so they don't completely enter and exit through the body in the same way that an X-ray does. And so they travel a certain distance and then they stop. And so that can be helpful when there is something, deeper that you want to spare from even low dose radiation. We really have a lot more sophisticated technology, even with traditional X-rays or photons compared to, 10, 20 years ago, where we can still get really conformal radiation plans. Our overall goal, regardless of the type of technology used, is we want to treat the tumor, and we want to treat the tumor with the adequate dose, but we really want to minimize and give the lowest possible dose to underlying, nearby healthy organs. So for a patient with a breast cancer, examples of what we want to treat are the breast tissue itself or the chest wall if the patient's had a mastectomy. And then in some higher risk patients, perhaps also lymph node regions. And so things that we don't want to get too much radiation dose, for example, would be the underlying heart and lung. And so electrons are great when you want to treat a target that's not too deep. So for example, a woman who may have a chest wall after mastectomy who decided not to have a reconstruction or implant, and so has decided to go flat after her surgery, then electrons may be a good way to treat that tissue that's at risk for recurrence and kind of minimizing dose to underlying heart and lung. And then conversely, if you have a patient who has, intact breast, maybe just had a lumpectomy and, we're treating her right-sided breast cancer with lymph nodes, or even the left side, just the breast alone, we can get a really wonderful and safe radiation plan with just the traditional X-rays. But there may be some patients with some more challenging anatomy. So for example, patients with left-sided breast cancers where we need to treat the lymph nodes, or left-sided breast cancers where the tumor bed is really in that central part of the left breast closer to the heart, where certain techniques may not be available to optimally reduce the dose to the heart. You may want to explore things like protons. I would say really the key here is that every single patient has unique anatomy. Mm-hmm. And so really what is best for each patient is usually decided on a patient level based on his or her anatomy. And so really, I think those are great questions to ask your radiation oncologist on what do you think the best treatment is for me? What should I consider? And then sometimes multiple types of radiation will be considered before the best decision is reached.
Okay, got you. Do you know why, and this is what I see in the clinic, why proton is a little bit more it's stronger on the skin? We tend to see a little bit more worse skin reaction on proton versus photon.
Yeah, that's true. So because, the protons enter and then they don't have as much exit dose, they do have a higher skin dose, where a lot of the X-rays have a skin sparing property where a lot of the dose doesn't build up until you get deeper into the tissue. And that's not the case with protons. And because of that, the skin gets a higher dose, and higher dose means higher skin toxicity. Skin toxicity is usually exhibited by redness of the skin, or, sometimes even peeling or blistering of the skin. And so we certainly see with our proton patients, often more skin effects.
Got you. Are you guys using anything in particular for skin radiation in Vanderbilt?
I would say it's a mixed bag. I think each, physician may have certain preferences, and then some patients have certain preferences of their own as well. And usually if I have a patient who already has something that they want to use, as long as I think it's safe, I'm usually fine with them starting out what they're interested in using. We use a lot of Aquaphor here or CeraVe. And then I do tend to use a lot of Strata XRT for my patients as well, although the cost is a barrier. So only really with certain insurance companies are we able to get our coupon codes to work. So we really want to be mindful too about the financial costs of whatever we're deciding to use.
Can you tell us a little bit about the Strata? Again, I have seen amazing results with it. So how can you explain it a little bit?
Yeah, it's kind of forms almost like this. It's a clear gel, and it's like it creates this like film. or layer. So it's applied twice per day. It doesn't have to be actively washed off. And, you have to write a prescription. It was developed by a company, and I think it's been trialed, and the results are really encouraging on reducing the skin toxicity. But the main trade-off is the expense.
Got you. Okay. Is anything that you have that will be of value for our audience, and will you share it with us?
Yeah. I think one thing that I'd like to just share is that there can be a lot of unknowns about radiation. As I said earlier, even some medical professionals may not know exactly what radiation is. And so we certainly know that a lot of patients come to see us, maybe either never knowing what radiation is or having some preconceived, notions, because maybe they've had a family member who's had radiation. And I think it's important to note that while radiation can have very serious side effects, technology has come a long way. And so someone who was treated for radiation 20, 30 years ago is going to be, very different than someone who's been treated in more modern times. And then also radiation side effects are really based on where the radiation is being delivered, because it's a local treatment. And therefore, a patient who's undergoing radiation for breast cancer, for example, is going to have a totally different experience with a total different list of potential side effects than someone who's undergoing radiation to a different body site, for example, like for throat cancer. So not only are the side effects different based on part of the body because of the nearby organs, but also different types of cancer require different doses of radiation. And typically, the higher the dose, the higher the risk of side effects. And so I think it's just important to note that no two patients are alike in general, but also the radiation is very different based on body location. We're trying to gather information.
Yeah, and you're so right. I started doing this about 15 years ago, and I used to kind of sit when you guys got together for like radiation oncology, meetings every Friday, try to understand all the physics, which is very complicated, and the lingering of like, the PTV and so forth. But I used to be able to kind of like identify, based on this history, more likely this is the protocol they're going to do. No way now. It's so changed so much. Like they keep talking about hypofractionated, like, these old protocols, like, only 4 weeks or maybe once for 3 weeks. Will you just kind of explain to us a little bit of like, used to be like everybody got it for 6 weeks every day, no matter what. Now, like what happened on this kind of like through the years, which is exciting because I know it's less effects for the patients, but just maybe a little bit kind of go in depth on that for me.
Yeah, I'm happy to. So, radiation, the way it works is it kills the tumor cells by causing damage to the DNA, which is part of the cancer cell. And so when it's time for those cells to grow and divide, they can't do that properly and they eventually die. But when we deliver radiation, it's not only the cancer cells that get exposed to the radiation. Some of the normal healthy cells do as well. But because those normal healthy cells are normal, they do have some ability to repair that damage caused by the radiation, while often cancer cells have some deficiencies in those DNA repair mechanisms so that they can't properly repair. And so when we give radiation, we very rarely want to give it in one big radiation dose and just one single treatment, because it's really time needs to be given in between treatments to allow those cells, normal cells that have the potential to repair, we need to give them time to repair. And that typical window that we need for repair is, at minimum 6 hours. And because of that, radiation is split into multiple treatments, usually given on a daily basis. In some scenarios, given twice a day. But when we give it twice a day, we make sure there's a 6-hour gap in between, and that's why. And so to really minimize the amount of radiation side effects, traditionally radiation, a little variation based on disease site, was given once daily, Monday through Friday, so on business days, over, 6, 7, sometimes even 8 weeks of treatment. There has been some research into looking at, can we hypofractionate, meaning we're giving a larger dose per day, but overall a lower number of treatments. And can we do that having the same control of the tumor, so our same cure rates, without increasing toxicity. And one of, there are many areas where there's been a lot of active research in hypofractionation. Two of the main ones have been prostate and breast cancer, and there are some radiobiology-based considerations for why those tumors, it's something called an alpha-beta ratio that I'm not going to go into kind of explaining, but there's some, basis for why we think these cancers will do well with hypofractionation. And certainly all the trials that have come out for breast cancer specifically have thus far shown that we can safely hypofractionate treatment for these patients with good outcomes and really less or similar toxicity. And I think, now it's very common to see 3 to 4 weeks of radiation for breast cancer, or even 1 week.
Yeah.
And even for some cancers, we may see that you only even will get 1 treatment, particular if you're ever able to really do a very highly technical and conformal plan. So maybe to like a very small tumor in the lung that's not near anything else critical, you may even see 1 or 3 treatments, something like an SBRT treatment if you're reading about that. And I think that's really been impactful for our patients because unfortunately we know that cancer treatments can really take a lot of time out of our patients' lives. And so that could be, time that they're having to take away from work or things that they enjoy, time away from taking care of others. And then we know many patients may not live in close proximity to a radiation treatment center as well. And so I think there are a lot of definitely a lot of pros with the ability to hyperfractionate more patients and get them through the radiation treatments quicker.
That's great. And again, I only see how the patient feels, right? So the quality of life definitely improves, skin improving, radiation fibrosis improving. So all those side effects is really exciting not to be able to keep up with you guys anymore. Because I'm like, patients ask me and I'm like, I used to be able to know anymore. It's like this thing changed so much month after month. So it's exciting. How can people find you?
Yeah, so I'm, as you said, I'm here in the Department of Radiation Oncology at Vanderbilt. So I do have a website where you can look me up. I'm not, I also have a Twitter account, but I'm not super active there, although I do post some things about our residency training program.
Perfect. And I will put that information on the podcast notes so people can have access to it. Is any 3 books would you recommend to the audience and why?
Sure. I would say I recommend, there's a book from a radiation oncologist that I know, Dr. Steven Rosenberg, called Cancer, What You Need to Know. And it really identifies 10, it's framed, the way it's written is that it identifies 10 common mistakes patients and families may make and how to overcome them. And I think it's just a great resource that, patients and families can read, but also students or other people in the healthcare field can find beneficial. Really breaks down a lot of things about cancer and cancer care in layman's terms.
Great. Any other ones?
Yeah, I think also the NCI, which is National Cancer Institute, a great booklet or resource for patients. You can also get it in the online PDF form, is Radiation Therapy and You, Support for People with Cancer. It answers a lot of common questions about radiation, really explains side effects and common medications as well as gives a list of suggested questions to ask your medical team.
Excellent.
And then for the 3rd book, I would say I would recommend people to really consider something that might be unique to them, and that's something that really inspires you. And that's going to be a different answer for every individual person. So for someone that might be, just something that gets them, lets them go to their mind go somewhere else. So maybe a science or fantasy novel, or, a beach read, or, maybe if they're a history buff, something nonfiction, or it could be something like a book on poetry or a book on faith. And so I think it's just important to think about something that's enjoyable and that is different for each individual.
Absolutely, which is just really bring a good point, right? Everything is about quality of life, right? So I know, I'm sure I have not been in my patient's shoes, but I'm sure it's difficult to have a diagnosis and then, treatments and secondary effects later on, and the fear of, is this gonna come back? When it's gonna come back? If it's gonna come back.
Right.
But I think it's important to always think like, let's just go back and just live, right? Let's just try to keep your life as normal as possible and do as normal as possible everyday stuff that you used to do before, or even enjoy it even more, right? Because sometimes when life throw a cancer diagnosis, it totally change your expectation or your perspective about life, right? So really it's just enjoying those moments and just really don't postpone things like, oh, I can do this trip later on. No, because you just don't know if it's going to be a later on. Just really enjoy yourself and just be smart about it, right? So if you're having head and neck radiation, you don't want to go on the beach and then you really have difficulties, with the skin burning more or anything on those lines. But definitely enjoy what you like to do, and that really was going to make things a little bit easier as you're going through these treatments. So so you kind of got the experience when you were working with us about how much we really integrate physical therapy when the patients are going through radiation. Will you just have you noticed, do you guys do the same thing in Vanderbilt? Do you notice a difference when patients were going into PT, like, a UF, we get a referral for everyone right away, and we try to see everyone going through these treatments. You want to tell us a little bit what you notice on your patients and whatever you guys do now over there?
Yeah, absolutely. I wish every patient here got an automatic referral, which is standard at UF, because I think it's very impactful for our patients. And, I think every patient can benefit from a really good assessment by a physical therapist with recommendations. So here it's kind of based on if the patient need is referred. It's not an automatic thing. I treat right now a lot of my practice is head and neck patients who certainly have a lot of challenges. And we typically are very aggressive in referring them to physical therapy, especially towards the end of treatment. But if we know that they have even some pre-existing comorbidities, then we'll refer them early on. And we also partner with a physical medicine and rehabilitation team that also really partners with us and is also extremely helpful in finding physical therapists closer to home for patients too who may be traveling from afar.
Okay, that's very helpful. Are you guys using any lymphedema pumps?
We run into some issues with insurance coverage, but for patients whose insurance cover those, well, we are using those frequently.
All right. I have another question, and then I just happen to have a student that is actually today I have to miss her in service about tumor environment. So has been more research about, how exercise really can enhance a lot of tumor reaction to radiation or chemotherapy. Do you know much about it? You want to tell us a little bit about that? What have you heard?
Yeah, that's a great question. So it's not anything that I've personally done a lot of active, research in, but we certainly know, for example, for breast cancer, one of the few things that's been shown to combat radiation-related fatigue is continued kind of light exercise and activity. And so I certainly think there is data out there to support how important that is for some of relieving radiation side effects. And then, as you said, also active areas of research into actually tumor control as well.
Yeah. So that has been really exciting. Like, I know we were trying to look a lot of research in humans. That was a little bit more challenge to find. Has been a lot of on mice, where has been like really improving tons of, because you're increasing the hypoxia of the tumor, and then you just really helping out. So we try to really now try to see patients right before chemo, right before radiation, and get them to a high interval training. Just really moderated assistant to get that heart rate up there at 74% if it's possible, depending on the patient. And then, we know that we have seen a great list of amount of secondary effects. I couldn't tell you if we are changing the tumor environment or not, because there's no way for us to know that, but definitely it's really exciting to see how well they do when they do that versus when they don't. So so it's really kind of curious to see hopefully something else in humans coming out, because it has been really good results with mice. So that's kind of exciting to come. So maybe that's another thing that you can encourage there. So everybody can be a referral for PT over there, right?
Absolutely.
Okay. Any 3 movies that you would recommend to the audience?
Any 3 movies?
Movies? Yep.
I have to think about that. So, I would say, well, right now we're in the holiday season. So I really love, Home Alone and Christmas movies, just maybe more from the nostalgia. But I really love watching those as kids, as a kid with my family. And now that I love that my kids are kind of I have a 3 and a 5-year-old, where they're getting to the age where they can kind of sit through a movie. And so we kind of love doing that together as a family. Other movies I really love, I've always really loved Good Will Hunting. That's a movie my husband and I love to watch kind of together when we first started dating. And I always thought it was kind of an inspiring movie as well. And my third, I would say, is it's tough. I love to watch a lot of kind of movies in general, in the background. So if I had to add another to the list right now, especially thinking of what I've watched recently, might be The Holiday.
Oh, nice. Yep, perfect. Was this one question that you wish I will have asked you and will you have answered to wrap up?
Sure. I would say maybe I would wish you would have asked what do I love most about my job?
Okay.
And I would say it's really 2 things. It's the people, and people really encompasses both my patients, who are really why I do what I do and bring so much meaning to my life, but also the whole team that I get to interact with when I treat a patient, whether that's a surgeon, an oncologist, physical therapist, or radiation therapist, to really come together in a team environment to provide care for a patient. And then the second thing, in addition to people, is the opportunity to learn something new every day. And so we've talked about, even on our, on this session today, about how things have changed over the year. There's new research coming out on importance of, the environment and exercise. And so there's always new things to learn, and there will always be more to learn. Always hoping we can do better for our patients.
That's amazing. And this is what is so inspirational about me doing this podcast, is like, oh my God, I'm learning for each one of my guests so much every time. No matter that we work together, and no matter, if you're a patient survivor, or I've been talking with caregivers, mental health, I learned so much. It's really exciting to be able to, give all this education to people out there who needs it, and hopefully can help them a little bit through their journey. So I really appreciate you being part of it. Thank you so much.
Thank you for inviting me. Enjoyed it.
Okay, you take care, Dr. Lockney. We miss you.
You too. I miss y'all too. Bye-bye.
Bye.